what we're going to do in the next session is discuss how to partner effectively, how families can partner effectively to address medical concerns that impact sleep and also use medications. So I'm going to use an example. This was, believe it or not, Osmond's case from earlier that I've distilled into one slide. I've named the young gentleman Scott, and he's 16. He's a young man, and he's had sleep difficulties since birth, most prominently sleep onset delay, meaning difficulty falling asleep. And as we heard earlier, he was diagnosed with attention deficit hyperactivity disorder, major depressive disorder, oppositional defiant disorder, as well as autism spectrum disorder. And he was treated with 7 psychotropic medications between the ages of 2 and 16 years with no success. And in fact, he had significant medication side effects that were seen with all of his therapies, including obesity and obstructive sleep apnea, from the weight gain that goes along with these medications, and then apnea. You could be more prone if you're overweight. And then he was eventually diagnosed with restless leg syndrome, which we'll hear about, treated with iron as well as the medication gabapentin, which is used for sleep and restless legs. And this led to an improvement not only in his sleep onset delay, but in some of his behavioral symptoms as well. And the point that Osmond was making earlier is that it's very, very common for children and young adults on the autism spectrum to be medicated, over-medicated. So one medicine doesn't work, they're put on another, they're put on still another. And this is true. People will come to me, patients will come to me, families will come to me, and they're on melatonin and clonidine and Klonopin and trazodone and Tenex, and they're on everything. I mean, they're on like all these medicines all at once, and sometimes at very high doses. And the child is still not sleeping, and they've developed all these side effects. And sometimes the very first thing I try to do is to start whittling away at some of the medicines. And also looking, as was the case in Scott, for some other condition that may be disrupting the sleep that's more medically based and isn't necessarily, you want to really know, like if it's restless legs, you want to target your therapy toward that. If it's sleep apnea, you want to target your therapy toward that, rather than just adding on layer after layer of medication use. So I mentioned this earlier, the causes of insomnia, and what I want to focus in this part of the talk on are the medical, neurological, and other sleep disorders categories, and talk about each of these in a little bit more detail. So we developed a screening list within the Autism Treatment Network, and we've published it, my colleague Ann Reynolds and I from the University of Colorado, Denver, in sleep medicine clinics, looking at GI problems, seizures, pain, sleep disorders, psychiatric behavioral conditions, and also reviewing medications. And it looks like this, and it's something that the pediatrician can do very quickly, or the healthcare provider can do fairly quickly. And again, what helps is the parent can fill it out and bring it to the visit. So what the healthcare provider is doing, just like with the Children's Sleep Habits Questionnaire, is scanning it quickly and seeing if there are any yeses that need to be addressed. So does your child have a history of reflux? Does your child have constipation, abdominal pain, seizures, unusual events during the night? So this way, even if the parent doesn't know if the child is having a seizure, they could be asked about unusual events and then asked, is the event similar every time, which suggests a seizure because it's the same pathways in the brain firing. Does your child snore loudly? Does your child gasp for breath? Allergies, coughing at night, pain, dental pain, tooth pain, eczema, sensitivity to light. How much meat are they eating? Do they take a multivitamin with iron, which gets at the restless legs, which can go with iron deficiency, restless sleep, leg pains, growing pains, which can be symptoms of restless legs. So again, this is a quick and easy way for the family to partner with the healthcare provider to identify what the parent can provide, and then the healthcare provider can follow up. And then there are sleep disorders apart from insomnia, but which can contribute to insomnia. So we're going to talk about these in a little bit more detail: sleep apnea, restless legs, seizures. Starting with sleep apnea, I mentioned earlier it's not necessarily more common in children with autism, but it is really common in the general population. It's estimated to be about 2 to 6% of typically developing children, and it's important to treat, particularly, well, in any child, but in autism it may be contributing to some of the daytime symptoms. And the theory now, or the feeling now, is if you see a child with attention deficit symptoms who's typically developing, you always want to ask about sleep, and particularly sleep apnea, because they're very highly related. And similarly, a child with apnea may manifest their daytime sleep problems or their nighttime sleep problems as hyperactivity during the day. Many times as adults, when we're sleepy during the day if we haven't slept well at night. It comes out as sleepiness during the day. But in kids, it comes out less as sleepiness during the day and more as hyperactivity. It's almost like the child is trying to compensate and be more revved up for their lack of sleep. And what happens in apnea is when we're awake, we're able to breathe normally, we're able to control our airways, but when we go to sleep, everything relaxes, the tongue falls back, the muscles relax, and we stop breathing, and it's repetitive. So you'll stop breathing, you'll wake yourself up to breathe, you'll tighten your muscles, and then you'll go right back to sleep, and the cycle will start again. In kids, the tonsils and adenoids are oftentimes the culprits. Here's the tonsils, and they could even, when they're enlarged, they could even be kissing, meaning they come together and meet in the middle. The adenoids you can't necessarily see by opening up the mouth and looking, but they're in the back, and an ENT can see them, or you can see them on a lateral x-ray. And this is oftentimes one of the biggest causes of sleep apnea in children is overgrowth of the adenoids and tonsils. Obesity can also be a cause. We're right now in the middle of an obesity epidemic, particularly in the States with the sedentary behavior and all, and poor diets. Allergic rhinitis, can contribute. Craniofacial abnormalities, this comes into play less in autism and more in, let's say, Down syndrome or other neurodevelopmental disorders, some of which can have features consistent with autism. And then neuromuscular or hypotonia, which is also common in Down syndrome, can contribute. Usually there's multiple factors. Oftentimes there's a family history, so I'll always ask about whether, not just whether dad or mom have sleep apnea, but whether dad or mom are loud snorers, because sometimes we won't diagnose sleep apnea in the parent. We'll find out about it in the child first, and then we'll end up diagnosing the parent later, which is one of the fun things about doing family medicine sleep. I see all patients across the lifespan. These are some of the facial features that can contribute to sleep apnea. Small jaw can contribute, cleft palate. And the nocturnal symptoms include loud, continuous, nightly snoring, apneic pauses, paradoxical movement where the chest and the belly are moving opposite, restless sleep, sweating in sleep, abnormal sleep positions. Sometimes kids have been described to sleep on all fours with their head up to try to open up their airway. And they do that naturally, and it's something they've learned to do. Mouth breathing during the day, chronic nasal congestion, hyponasal speech, difficulty swallowing, morning headaches, frequent infections, or poor appetite. And then during the day, we may also see excessive daytime sleepiness, which manifests as difficulty waking up for school, falling asleep at inappropriate times, including during therapy sessions, increased naps. But then we may, instead of seeing the excessive daytime sleepiness, as I mentioned a few minutes ago, see more acting out, mood changes, inattention, ADHD, as well as academic problems. And then other associated features can be bedwetting, enuresis, growth failure, and then increase in partial arousal parasomnias. I'm going to get to parasomnias in a minute. This is sleepwalking, night terrors. You can actually have an increase in these abnormal movements during sleep if you're having apnea, because apnea can kind of disrupt your sleep and make it more likely to have these. And then an increase in seizure frequency has also been described in sleep apnea. So the treatment options, the first line treatment is adenotonsillectomy, removing the adenoids in the tonsils. If this does not work, we sometimes use CPAP, which is continuous positive airway pressure. And this involves using a machine that delivers pressurized air through a mask into the upper airway to splint open the airway and keep the airway open. And as you can imagine, it's challenging in any child, particularly a child with autism who may have sensory issues. And it's really interesting. I've had several kids with autism as well as several young adults tell me that they did okay with the mask, but what really bothered them was the machine. The noise of the machine really bothered them, even though it's not that loud. Over the years, the technology has really improved to where it's almost more of a white noise sensation, but they really couldn't stand having any sort of unusual noise. So that was really interesting to me, but the sensory issues really do come up. We do work with kids, young adults, to desensitize them, meaning we'll prescribe a mask and let them take it home, wear it watching TV or a video where they can kind of get used to it. They can wear it 10 minutes and then the next day 15 minutes and gradually increase use, and then eventually wear it with sleep. And this is where therapists can really make a big difference. So that's the treatment there. There's some other treatments, including jaw surgery. There's some orthodontic treatments that have been developed for sleep apnea in the general population that may be effective as well. But the bottom line is I wanted it to be on your radar because it is really common. It does affect behavior. It also has health issues, and it's something we don't want to miss. The way we diagnose sleep apnea is through an overnight sleep study or polysomnography, because just getting a report of snoring or noisy breathing is oftentimes not enough. Sometimes I'll have a report of snoring, noisy breathing, even pauses in breathing. I'll do a sleep study. The sleep study will be normal. I'll call up the mom or dad with some trepidation because I feel like they're going to say to me, "What do you mean the sleep study was normal? My child is stopping breathing." And then they'll say to me, "Oh, that's great. I'm so relieved. I'm so reassured." I'm like, "Well, I thought they were snoring and stopping breathing." "Oh, they were, but I think it was because Johnny had a cold that week or whatever." So, it's really important. We don't want to subject kids to having their tonsils come out and have surgery if they don't really need it. And sometimes we've found that the symptoms can be very transient. The flip side can also happen. It can be very subtle. It can be the parent may not know that their child is pausing or stopping breathing. They may just hear some noisy breathing, but the child is waking up at night, and it's enough for me to say, the child is waking up. I don't know for sure what's going on here. Dad is a snorer. I want to be absolutely sure. I'll do the study, and sure enough, they'll have sleep apnea, and it could even be pretty severe. So there is not a great correlation, even in typically developing kids, between the symptoms of snoring and noisy breathing and what we find on the sleep study. And it's actually even harder in kids with autism because, at least in typically developing kids, we oftentimes will have evidence that they're having some behavioral problem during the day, inattention, hyperactivity, irritability. In kids with autism, they may be having those daytime problems because of their autism. So it's hard to really know if they're, it's hard to really figure out based on their nocturnal symptoms whether we're dealing with sleep apnea or not without doing a sleep study. So what do we do in a sleep study? First of all, we measure sleep, but one of the questions I get is it really valid to measure my child's sleep when they come into a lab and they have all these wires on them and they're all hooked up and they're in a strange, unusual place? And the answer is no, it's not going to be normal sleep. What we're really interested in is not capturing their normal sleep, but whether something is happening in their sleep that is amiss, that isn't correct. So we may not see this beautiful sleep we call it sleep architecture, which is a diagram of, as the night goes on, what's happening to their sleep stages. Normally we enter sleep through non-REM, 1, 2, 3, 4, and then about 90 minutes after sleep onset, we hit our first REM period. Infants actually enter sleep through REM. Over the course of the night, we have more and more of the REM sleep and less of the non-REM sleep. We'll actually come back to this when we talk about these night terrors and sleepwalking. Those are disorders that oftentimes come out of the first part of the night and out of deep sleep, which is most prominent in the first part of the night. This is how we can tell what stage of sleep a child is in based on the EEG. This is the awake EEG. You can see kind of densely packed waves. Stage 1 looks similar. Stage 2, we start seeing features. They call them either K-complexes or sleep spindles that are either these really high waves or more close together packed waves. And then stage 3 and 4, which we're now calling N3 sleep or deep sleep, is these high slow waves that we see throughout those stages. And then REM sleep, rapid eye movement sleep, is when most of us dream, and we also can have nightmares out of REM sleep. During REM sleep, the EEG looks similar to during light sleep or stage 1 sleep, but we also can monitor eye movements and we can monitor chin tone. And if the chin tone goes really low, that's a symptom that we're in REM sleep. And if the eyes start moving around really quickly, that's a symptom that we're in REM sleep. So we can use the whole eye leads, chin leads, EEG to help figure out what stage of sleep we're in. And then this is another example of a hypnogram or a graph of what somebody's sleep looks like. And you could see it took this child like 2 hours or even longer to fall asleep. So that's a good example of sleep onset delay in a child with autism.